Dr. Wessam Shokri, middle cranial artery occlusion on top of stenosis, how to deal.
Good morning all professors and colleagues. حابب أشكر أستاذي دكتور محمد أبو الهدى على التقديم، وأشكر دكتور عمرو وكل أساتذتي اللي كانوا في وقت من الأوقات بعد ربنا سبب إن إحنا نبقى واقفين ونشتغل الشغلانة دي. النهارده أنا هتكلم عن middle cerebral artery occlusion on top of stenosis, how to deal with such situation. As we all know, mechanical thrombectomy is now the standard of care in treating patients with acute stroke with large vessel occlusion, and this was since 2015. In the first 6 hours, then it developed in 2018 up to 24 hours, and lastly we are treating the large volume stroke with low aspect score. The aim of mechanical thrombectomy, whatever the technique, using stent retriever or aspiration, is to achieve TK2B or TK3 recanalization. However, this is not the case in the daily practice. As we can see in this patient with left MC occlusion, we take our stent retriever to do mechanical thrombectomy, and after the first pass, the artery reoccludes. So we all have a hope to open the vessel. We go again and we try to open the vessel, but we have a lot of passes and we fail to open the vessel. So all the team in the cath lab get tired and we desperate to open the vessel. So what are the causes of failure? We have 10 to 20% failure, either failure to vascular access or to reach the target occlusion or to retrieve the thrombus. Half of the failure rate is due to underlying stenosis. When we go for MCA stenosis, we have to ask several questions. The first question, is there a way to predict that there is stenosis before going to do mechanical thrombectomy? And when to proceed? Should we leave the MCA if we open after mechanical thrombectomy and we see stenosis? Should we leave it or we go for angioplasty or stent? What about antiplatelet regimen given in the setting? And what are the type of stents we use? When to proceed? Nowadays, we talk about at least 3 failed passes. If we have the 3 failed passes, we should think that there is another cause that occlude the artery. Also, a procedure more than 90 minutes, we are trying to open the vessel, we should think about a next step to open the artery. Is there a clue to predict by imaging? Yes, in the non-contrast CT, we know that there is the hyperdense sign. If it is absent, we should think about that it could be related to underlying stenosis. Another way with CT angiography, that the CT angiography can determine 2 types of occlusion. The first type of occlusion is we call branching site occlusion. The MCA, the main trunk, is not clearly observed. If we don't see the middle cerebral artery clearly observed, we call this branching type occlusion. But if the main trunk we can see with CT angiography, we call this type truncal occlusion. The truncal occlusion is due to a rupture of a plaque, and this can help us to determine that this patient has underlying stenosis and that caused acute stroke. What about antiplatelet? Since the era of mechanical thrombectomy, the stroke guidelines recommended the use of antiplatelet after mechanical thrombectomy after 24 hours from treatment. There is no consensus about the regimen used in emergency stenting during mechanical thrombectomy. But several studies went out. One, the last year, it traced the use of single antiplatelet before mechanical thrombectomy, and they concluded that monotherapy did not improve the functional independence. However, it did not increase the hemorrhagic risk. And so we can use this info that using antiplatelet even before mechanical thrombectomy does not carry an increased risk, and we can prepare our patient if we see such a situation. Also, another study on 102 patients, no significant difference in mortality or intracranial hemorrhage between patients who took aspirin and without taking aspirin. They all agreed about aggressive antiplatelet therapy is essential to maintain stent patency. We have three options to give the patient. Either we give the patient glycoprotein 2B3A inhibitors with a bolus of 0.4 microgram per kg over 30 minutes. Then we continue for a maintenance dose of 0.1 microgram per kg. Then we introduce our double antiplatelet after 24 hours. The other option is to give the patient IV aspirin as a bolus, but we don't have this in Egypt. And the third option is to load the patient on the table during mechanical thrombectomy with double antiplatelet, aspirin and clopidogrel. Okay, to stent or not to stent. It was published last year, a big meta-analysis about rescue stenting for failed mechanical thrombectomy in acute stroke. They ended by that on conservative treatment, the mortality rate is higher and the intracranial hemorrhage is similar to the patient who got stenting. The other issue is the functional independency on 3 months is much better with patient who got stenting for the middle cerebral artery. So the aim is to do a good recanalization and good flow to the brain. What type of stent we have? As we know, 2 types of stent. We can use closed cell nitinol stent like the Atlas, or one of the stent retriever we can deploy after doing mechanical thrombectomy. We can use this stent and deploy the stent. The other type of stent is the balloon mounted coronary stent. I think in our country it's better to use this type of stent because it is more cheaper, but it has the problem of the delivery. The delivery system of balloon mounted is very challenging, especially in very tortuous anatomy. But we have to be ready with different types of stent. I will show you my experience in 13 cases treated mechanical thrombectomy with underlying MCA stenosis. 7 patients I did angioplasty with stents. In all patients, at least 15-minute repeated angio to assess vessel reocclusion before going to take the decision to do angioplasty and stenting. The modified Rankin scale assessing the patient functional independency before treatment was 4 to 5. Only 1 patient received tissue plasminogen activator. I started with a angioplasty balloon 1.5, then I upgraded to, in some patients, to 3 millimeter balloon. 4 stents used were balloon mounted coronary stent. All patients were loaded with clopidogrel and aspirin. 1 patient only received ticagrelor. Half of the patient took aspirin in the ER, and maybe this was helping the patient that the stent was patent. All had a follow-up CT as a routine. Significant intracranial hemorrhage occurred in 1 patient. 2 patients died, 1 of them not due to a non-neurological cause. And 1 patient out of the 7 patients, the stent was occluded. But this patient, he has very good collateral, and the modified Rankin scale dropped to 2. Here are some examples of the cases. The image on the left, we can see residual left proximal MCA stenosis, and I placed a self expandable stent, the Credo stent, and then I did angioplasty inside the stent, and the image on the right is the control angiogram with full restoration of the flow and regain of the caliber of the middle cerebral artery. This is another patient. We can see it is not see clearly, but this is the stent retriever opening the vessel after removing and taking control, we can see there is residual stenosis in the proximal MCA. So I go for doing angioplasty, and then I placed a balloon-mounted stent, and this is the final control angiogram. This is another patient, and we can see when we see the residual stenosis and the vessel is getting occluded, the flow is very poor and is not going to the whole territory. So we must open the vessel, we must not leave the patient like this. And this is a video showing the balloon mounted stent across the lesion. And this is the flow after deploying the stent. And this is in a non-subtracted image. You can see the markers of the stent. Lastly, I want to show this patient. This was an 80 years old female having a non-ruptured basilar tip aneurysm. And this patient had acute stroke in the form of dysarthria and right-sided dense weakness. The MRA was showing stenosis in the MCA, and while we went for mechanical thrombectomy, the artery was totally occluded. On the image on the left, we did a mechanical thrombectomy with our stent retriever. We took the control angiogram, the artery re-occluded. So for this patient, I decided only to do angioplasty alone, not to place a stent. I used a balloon, as I told before, from 1.5 up to 3 millimeter, and this is the final control angiogram. And this patient was kept for 1.5 months. The artery was patent, but the family was refusing to do another procedure to place the stent. And unfortunately, the patient got another attack of stroke on the same artery, but she didn't then do anything, unfortunately. So to take home message, non-invasive imaging pre-thrombectomy can predict underlying stenosis. Rescue stenting is safe and is advised to achieve good recanalization and good outcome. And the risk of intracranial hemorrhage is similar to conservative approach. So don't fear to place the stent and to give the patient antiplatelet. Knowing from literature that colleagues are using IV glycoprotein 2B3A inhibitor, so we can shift our practice here to start this with no fear of hemorrhage. And we should also think about finally that angioplasty alone could achieve a good outcome, and then we can schedule our patient for another session to deploy and place a stent. Thank you.
Many thanks, Wessam, for this informative topic. والحقيقة برضو ده topic very important. زي ما كنا بنتكلم على التاندم اوكلوجن، وبيبقى فيه دايما ديبيت انك تدي انتي بليتلتس للبيشنتس ولا لا بعد ما تديبلوي الستنت. فأنا بشكر دكتور وسام على ال very good presentation. وهل في أي questions للدكتور وسام؟
Thank you.
Okay, we will.
Thank you, Wessam, for your talk. For most people who don't know how difficult it is to take a decision to place an intracranial stent, it is very, very, very difficult at very stressful times. So having a series of 13 cases, this is something very, very impressive. I have a question for you. What type of stent do you use?
Usually, I'm now shifting to use a balloon-mounted stent. But my advice when we use it, it's preferable to have an intermediate catheter, because there is difficulty to deliver this
Yes,
this
I
stent to the MCA. So in 2 of patient I used distal access catheter to be able to deploy the stent.
I know that the length of the coronary stents, the shaft of the coronary stent is 140 centimeters.
Yeah.
What intermediate catheter length do you use?
Usually I used in this patient the catalyst. The
115?
Yeah.
Yes. Very good choice, and thank you.